you explain it again with the 3D filter?
Sorry?
Could you explain again what the 3D nerve fiber does?
It is a fast pain. So the sensitivity will go up of the 3B nerve fiber. And if the sensitivity goes up, that means that it will be released sooner. It's more active. So with a light touch, it will give a signal up.
Is this after an injury or just?
After an injury, most of the time. But this will all come back. Sensitization. What is sensitization? Decrease of the stimulus needed to reach the threshold. Increase of response to a given stimulus. And after the discharge, we can have continued discharges. And development of spontaneous discharge. Spasm. Okay, so if we talk about sensitization, it's a lowered threshold.
What's the AP discharge?
Action potential. Action potential. Okay, now I have a picture that everybody knows, should know. The large fibers, small fibers. It's on C10. Large fibers come in, substantia gelatinosa, T-cell action system. What can we do? If we stimulate the large fibers, the pain will go down, or the pain sensation will go down. It will close the gate control theory. And if we stimulate the small fibers, it will go up. There will be pain. Okay, everybody knows this. This is not anything new, I hope. And you can read it in your handout. Okay, another important factor is, and this perhaps is a little bit new now, is what are we going to do with axial transport, exoplasmatic transport? This is on C12. What we can say is that a nerve is more than just something, some item which has axipotentials. It is more. It has an inner structure in which filaments can travel, in which a lot of stuff can travel. Substance P travels in there. So it is more. So we must see that it has a cytoplasm. It has 5 times more viscous than an exoplasm. It has smooth endoplasmatic reticulum, ribosomes, and microtubules. So what will happen is there is a travel over the nerve, inside the nerve, just like a blood flow. What will happen is there is a stream towards the organ, and there is a stream towards the spinal cord. So in one nerve, we can have 2 flows, to the periphery and to central. What we will do is, if something comes out of the spinal ganglion, and something will come out of it, 80% will go to the organ, and 20% will go to central. This flow is, for example, for substance P, is 400 millimeters per day. And the book of Butler mentions that the stream up is 200 millimeters a day. That is something that could be, could not be. I mean, so we will keep it for now as 400 millimeters to the end or back. We call this the antegrade flow and the retrograde flow, or orthodrome and antidrome. So there are more things going on, and we should realize that. What CORE states is that many disorders we treat and responses from treatment may be related to axonal transport system. And that is, it could be. What I would like to do, for example, the Mills manipulation or the Mills movement, everybody knows that one, is this motion. What are we doing there? I mean, are we tearing apart fibers? Or are we stretching the radial nerve? Because it sounds familiar, like a radial nerve. That is something you can think about. I mean, I would really encourage you to read some things from CORE. I don't know if David if David agrees with that, but he has done a marvelous job. If we talk about sensations, let's go back one moment. What we have here, why I draw this, is because in the spinal ganglion, substance P will be produced. So we have substance P at the end, at the organ site, and we have substance P in the spinal ganglion, which produces the substance P. And then we have, of course, substance P at the spinal cord. If we have an injury at the organ site, and it could be an ankle, or it could be a wrist, it could be something else, then substance P opens up in the interstitium, goes out, and has those reactions where we talked about, and then it's empty, because it is not a permanent thing out there. What will happen then, the spinal ganglion will produce it. The spinal ganglion will produce the substance P again, but it will take time to get to the organ. And that's why if you twist your ankle, in the beginning you have swelling, normally, and then you think, oh, it's not too bad actually. Then after a while it gets worse again. That could be related to the substance P.
Chris, who was the author you just quoted?
CORE. Irvin CORE.
CORE.
CORE. K-O-R-R. Irvin CORE. And the reference is in the back of your manual. Okay, so we have a couple of sensations. We have the primary pain, we have the secondary pain, primary hyperalgesia, the first phase, second phase, and the secondary hyperalgesia. Is this new stuff for most of us? Or is somebody familiar with this? Okay, great. For now, we will start with the primary hyperalgesia to talk about that. So the primary hyperalgesia, the localization is at the spot of the injury. The reason is a decreased threshold for nociception. The substance P, as we have seen, sensitizes the 3B afferent. And the prostaglandin, sensitizes the 4 afferent. So these two work together. The first phase will happen when the substance P is released at the injury site, so at the nerve ending. That's number one. And then we have the second phase, in which, as we have seen, that from the spinal ganglion, the substance P must travel to the nerve ending. Give the second reaction. And that is the second phase of the primary hyperalgesia. The distance determines the time. So the distance between the spinal ganglion and the injury site. Exoplasmatic transport, as we have seen, is 40 centimeters per 24 hours. So for example, if we have a shoulder injury, it will take 12 hours. So you hurt your shoulder, substance P releases. Then after 12 hours, the nerve endings again have that substance P. And of course, if we are talking about the substance P, the recruitment is also from the surrounding areas at the injury site. But that's minimal. We're not talking about the big chunk that comes in. The shoulder injury is 12 hours. The distance is 20 centimeters between the spinal ganglion. 20 centimeters is 20 divided by 40 is 12 hours. That's half a day. The ankle injury will take 3 days. Because the distance from the spinal ganglion to the ankle is 120 centimeters. Most of the time. With some people it's shorter, with some people it's longer. So 120 divided by 40 will be 3 days. And perhaps this is even handy because when we have our legs most of the time are longer. So if we are in a situation that we must flight, an emergency situation, so that we jump out of a tree, we twist our ankle, that it will take a longer time period to swell up again. So we can bring ourselves into safety. So this is the primary hyperalgesia. Then we have the secondary hyperalgesia. And the secondary hyperalgesia is something different. The localization will be in the dermatome, in the myotome, and in the sclerotome. So in everything that has to do with the nerve. The reason is an overflow of substance P in the spinal ganglion. So we have that spinal ganglion, and there is not only one neuron in there, there are more. There will be a big production of substance P. So there will also be the neuron for the dermatome, for the myotome, for everything. So there will be an overflow of substance P that goes in the periphery. Gives an increase of substance P in the entire segment. The effect of this is that we have more substance P than normal in the entire segment. So it will be hyperreactive. A light stimulus will release histamine that will increase the response of substance P. So what it says is if we have a skin, and if we touch that or with a pinwheel, normally it will give a reddened response. Perhaps because we have more substance P in that segment, if we use the pinwheel, histamine will be released, and the substance P is more, and it will give a bigger reaction. The consequence for us is, perhaps is this a facilitated segment? Or perhaps it will help to be a facilitated segment. And referred sensations. Because it is more sensitive. If substance P is there, also prostaglandin will be there. And this is the secondary hyperalgesia.
What kind of a time frame are you looking at for this response then? Is it real general? Is it bigger?
It is more global, it's more general. Basically, you can say that in the immediate areas of the segment, it will be sooner than in the rest because it has to travel over there. So for example, if we take a look at the spinal column, if you have an injury there, or you have an injury at the wrist, goes back to the spinal column, etc., then one of the things that will be first hit is the medial dorsal ramus, and because it's really close by. And then the skin at the wrist will be later, because it takes time. More questions? Okay, we're going to the primary pain. Primary pain is going to the spinal cord. So we've talked now about the injury site. That's very important for us. Now we're getting back to the spinal. It's before the primary hyperalgesia. Activation of the unimodal sensors. It runs through the 3B fibers, fast pain. It gives also an activation of the polymodal sensors, and that's the 4 fibers, that's a slow one. And substance P will occur at lamina 5 in the rex laminae. The activity of the 3B fibers, the fast pain, will mask the activity of the 4 fibers at spinal level in the beginning. So if you have a fast pain, that's more intense than the slow pain. Except the fast pain is only a twitch, and the 4 pain basically takes on for a longer time period and is more aching. If we wrap everything up together tomorrow, then this will definitely come back. The secondary pain. Then we are going to travel again. This is the substance P from the spinal ganglion to the spinal cord. So that's the retrograde transport. The distance of the spinal ganglion to the cord determines the time. Again, exoplasmatic transport is 40 centimeters per 24 hours. Or, if Butler says, 20 centimeters. Whatever. I mean, this is just the concept right now. So a shoulder injury, the distance is 2 centimeters. Because the spinal ganglion is awfully close to the spinal cord, of course. 2 divided by 40 is 1.5 hours. So 1.5 hours later, you will have your second pain. Ankle injury is 6 hours. Why is it 6 hours? Because the distance of the spinal ganglion to the cord, because the cord does not go lower than L2, it will take longer. So what we have is a distance of 12 centimeters. 12 divided by 40 is 6 hours. What? So what we have on spinal cord level, this is the intensity. So the fast pain covers the 4 pain. So the 3B pain covers the 4 pain. It goes down together because the 3B will end, because there is no reason. They adapt faster. And the 4, again the substance P also at spinal cord level, will be resolved, is up, is gone. And then it comes back, and then we're going into the secondary pain. So to recap this a little bit, perhaps that will help. If we have an injury, the prostaglandin will go up and the substance P will go up. The prostaglandin takes care of the 4 fibers. The substance P will take care of the 3B fibers. It sensitizes. So if there is substance P, if you have your ankle injury, you twisted your ankle, substance P, prostaglandin, etc., etc. Prostaglandins will cause the aching pain. The substance P will make sure that if you twitch it again, if you touch it, you will have a fast pain. That's substance P. Substance P also causes the edema, as we've talked about.
Is substance P affected by anti-inflammatories the way prostaglandins are?
Yes. That's something we will talk about later. We will talk about what can we do with anti-inflammatories and is it useful. But that will be if we have discussed the tissue repair stuff. Okay? So this is the story about the sensitization. Now, how are we going to put it in sequence? I mean, what will happen if we have an injury? So you twist your ankle. What will be first? The first one is hard to get at, because I don't know what will be sooner, the primary pain or the primary hyperalgesia. So let's say for now the primary pain will be first, because that will be the exipotentials, and substance P needs time to be released. So first we have the primary pain. Okay, everybody agrees? Number two, what would be number two? The primary hyperalgesia. Then the first phase, am I right? Okay, number three, what will be number three? Ken.
Not sure. I don't know why. First phase. Secondary pain.
Secondary pain, great. Secondary pain. Number four. And that's again a little bit up and down. 4 will be probably the beginning of the secondary hyperalgesia. So the beginning of the secondary. And number 5 will be the primary hyperalgesia, the second phase. That's at the injury site. That will take the longest time. Okay? Other questions about this? Normally I would take more time to bring this over, but in this course with David, I would like everybody has as much time as with David as possible. So that's why we'll fly a little bit through it. Okay, the supraspinal pain. We will discuss this a little bit later. It will be discussed in the second or in the third. Yes, Brian?
Are you going to get to later what turns off the spinal ganglion from producing substance P?
What it turned off?
What makes it stop producing substance P?
Yes. Yeah. But that will be also in the tissue injury repair. Okay?
Number 5, is that secondary hyperalgesia?
Yes.
Phase 2 of...
Oh, sorry. This will be the primary hyperalgesia second phase. Yeah. Please try to understand this concept a little bit. The supraspinal pain we will discuss later, because then we are also going to include motivation, etc., etc. What also is important if we see this is, for example, if we talk about the difference between a proximal injury and a distal injury. Is that a proximal injury, let's say a shoulder problem or a rib problem? It has a low innervation per surface unit. So what will that mean? So there are less C fibers or less 4 fibers. Pain is hard to describe and to localize. It will give you referred sensations. There will be a weak local inflammation because there will be less nerve endings. If there are less nerve endings, we will have less substance P. In return, we have more blood flow in that area. A shoulder does not swell as bad as a finger. Why is that? Because there are more nerve endings and less blood flow. If you take a look at the distal injury, how that will look like is completely the opposite. Is then we have a high innervation per surface unit. We have a strong local inflammation. And the pain is really localized, easy to describe, and minor referred sensations. Because we have more nerve endings. So the discrimination is easier to perform by us. And also the deeper it is, the harder it is. For example, an organ has a weak local inflammation if it is painful. And it will give a lot of referred sensations.
Chris, I don't understand the leap to why you get more referred sensations in the proximus. Does it just have nowhere else to go? Or I'm not sure what
It will revert back. It will have a bigger area in the joint. So it will go back to the spinal cord, and it will distribute to a bigger area in which more areas are involved. And if it is the finger, it's really tiny and it goes back to the spinal cord and it's tiny again. Okay? Now we're going to make a jump. This is a little bit in preparation of the rest we're going to do. The manual therapy methods, as I see them. I mean, now we're going a little bit in personal things. And that's on page. Great. Okay. This is a little bit already in advance. What is important with manual therapy is that we perform an assessment of the dysfunction. And basically that's the big picture. That is what we already do. The biomechanical assessment, CEREX protocol, etc., etc. Another important part is the assessment of the relation between the load and the load capacity. So what is the load? And what is the load capacity? And we can subsidize that in local and in general. That is something we will do in the next session. Assessment of the selectivity of the nervous system. Interesting is, what is selectivity and how can we assess it? Assessment whether this dysfunction is an indication for manual therapy. Can we do something with it? Or shouldn't we? And of course the choice of technique. And we will